old because it was 50 years ago when I first read it. And it's really scary. A lot of it has happened.
I always enjoy Animal Farm too.
Yes. Well, you read the same important books I read.
They're classic.
How about Atlas Shrugged?
Which one?
Atlas Shrugged. And
No, I don't read that. I don't agree with that political philosophy.
that much about it. I just know his
Much of the faculty were in neurology. All the faculty. Even Dr. Sarkis was read. And when you be really good or not, they've got such a broad base talent all over, but mostly American.
No, we're going to have them.
Okay, we'll start with an opening.
Had a policy that they would always bring in a new chairman from another school.
Not responding very well.
What's that?
Not responding very
Well, we now have the policy outside, but it's purely on a financial basis.
It may be that multiple people are logged in.
Yeah.
I mean, it's like
In radiology, we are still without a permanent chair.
Right, did you get the
Not a board one.
So, before Dr. Nazarian gets started, what's our process for signing in now?
All right, good morning, everyone. My name is Tremaine Williams. I'm from the CME office. I'm here to walk you through your first attempt at registry for your grand rounds from now on. Each week, I will provide Brian with some two pieces of basic information. It's an event code and a phone number for you to call in. There are multiple ways that you can register using this new system called Clancy. I've given Brian some copies of the ways that you can register. There's an app for you all that are heavy app users. There's an app for the iPhone or the Android, or if you have any of those operating systems. There's also, you also have the ability to use your mobile browser to log in, or you can log in from a laptop or desktop computer as well. Today, the method that we're going to use for the sake of simplicity and time is the cell phone calling system. I want to take a moment to show you all how to do that. So if you have, everyone has a cell phone with you?
No.
Okay. Okay. And Brian has told me that there are some of you that don't use cell phones. So there's a contingency plan in place for that. Brian will walk you all through that. If you take a moment, I'm going to give you two pieces of information: a phone number to call in, and also an event code to enter. If you can't hear me, I've given Brian a copy of this event code. The phone number to call in is 501-553-9108. It's going to prompt you to enter an event code. So go ahead and hit dial.
It's going to get jammed up if everybody calls at the same time, right?
No, it can hold up to 70,000 people at a time.
Oh.
The event code is 276001.
And will this be the same number forever for doing this?
Can you repeat that, please?
Yes. Oh, the event code is 276001. And this phone number, if you want to use your cell phones to dial in every time, and that's your preferred method of registering, it'll be the same phone number each week, so you can go ahead and save that number.
Good question. How do they know it's us?
It identifies you by your cell phone number. We have everyone in our CMU tracker system, your cell phone numbers and a profile. So the Clancy system collects a few basic pieces of information, and that's your cell phone number, the event code of the event, and uses the cell phone number as the primary identifier for who you are. Overnight, or at midnight every night, it sends that file to our tracker transcript system and populates those credits to your transcript. So that's one of the exciting bonuses of this new system, is that your transcripts will now be updated within 24 hours, as opposed to the 2 months that it currently takes to process that information. So was it successful for everyone? Okay, well great. Does anyone have any other questions?
I assume the event code changes every.
Yes, the event code will change every single week. And Brian and Miranda will set some parameters. One of the most common questions I get is, can you go home and register? You can, but it's determined by the course director and the CME associate on what those parameters are. So if they want to allow you to register up until midnight that night, they can. Or they can only allow you to register between the time frame of each specific activity. So once Brian gives me the official parameters, I'll set them, and he can notify you all of what those are. Any more questions? All right, well, for those participants who come in late, I'll leave the registration information here. And thank you all for taking the time.
Well, good morning, everybody. I guess some of you may not be familiar with the acronym, but all will be made clear before you leave this morning, so you'll genuinely be able to claim that little phone call that you just made. So why is idiopathic intracranial headache the headache that keeps on taking? Because it does. It takes away patient's vision. Not all patients. Going to discuss some of the details about that. But if I want you to take something home from this lecture today, it's not to think of idiopathic intracranial hypertension as a type of headache, but as a type of chronic optic neuropathy that is really very dangerous for the patient, because like glaucoma, the vision loss is very insidious. It's all peripheral. Patients don't really notice that there's something wrong until they start developing bruises on their heads and various parts of their body because they're banging into doorways and things like that. Oh gosh, that's not good. All right. So we're going to talk first of all about a patient that I saw not that long ago. A 25-year-old woman with 6-year history of headaches, mainly around the left eye, the vertex, left occiput. Don't go anywhere. Severity 6/10 to 13/10, and lasting days to weeks. Described as sharp, intense pressure. She has a prodrome of irritability. This is classic for migraine. So again, one of the things that you find out is that a lot of these patients' headaches are pseudomigranous in nature. There's no auras, but there's nausea, phonophobia, blurred vision, and transient visual obscuration, presyncope, and tinnitus. Now, a lot of these are also migraine features, except for the transient visual obscurations part. And for those of you that are not familiar with this, if you hang your head down for a long time and all of a sudden jump up, your vision will totally gray out. You've all had this experience. It's because all of a sudden you've tremendously dropped the perfusion pressure in your retina. But it returns very quickly. When you have increased pressure behind the orbit in the optic nerve, then the experience is much more enhanced. And even just a slight bending over to pick up something sets up a transient visual obscuration. She has some bulging of the eye and stuff like that. And she has triggers for these headaches. Weather changes, onset of menses, bright light, stress, sleep deprivation. Again, these are all migraine type of things, and not necessarily part of the IH spectrum. She's been tried on triptans, couldn't tolerate them. There's a strong family history of migraine over several generations. She was seen by one of her graduates of our program about 6 years ago, and she was diagnosed with Pseudotumor Cerebri at that time, which as we found is the older name for this condition. And she had 9 lumbar punctures. I don't have all the data, but I tend to believe her. And she at one point developed an aseptic meningitis, presumably as a result of too many taps. I could find one note that had 50 white cells on one of the taps, but multiple cultures, bacterial, fungal, and stuff were all negative, so nothing came of it. But it might have been a kind of an inflammatory process. She'd been on acetazolamide at doses as high as 5 grams per day. But as we'll discuss in some, and this is actually a tremendously high dose, but not for this condition. She ended up going off it. Her neurologist eventually referred her to our neurosurgeons. And at that point, she'd been actually taking these tremendously high dose of Diamox, and her discs were down, they were flat. So the neurosurgeon referred her to a neuro-ophthalmologist who confirmed the fact that she didn't have papilledema. But what was done next was probably not the best thing to do. She was taken off her Diamox, which she was more than happy to do. She was started to pyramid, which didn't really help. She eventually was referred to the UAMS headache clinic, where nortriptyline was started, which was quite a reasonable thing to do for a migraine. And that temporarily improved her headaches, but they returned. Past medical history, morbid obesity, obstructive sleep apnea, depression, chronic insomnia. She also had some recent onset of papilledema and dyspnea, but she was admitted to St. Vincent's, had some cardiac testing, and they looked for DVTs, didn't find anything. Put her on Lasix and potassium supplements. She's actually working full-time, going around the state taking pictures of school children. She drinks one type of carbonated beverage, which I didn't want to advertise on this lecture, but mostly she's drinking water. But that becomes an issue with people with migraine-type headaches consuming caffeine. It generally makes things worse. So she was pushing close to 400 pounds. She had some tenderness over the greater occipital nerve. She still had the pitting edema. I didn't hear anything suggestive of a heart failure. And now the discs were slightly elevated with small but present cups. The CD ratio for the students is the cup to disc ratio. And a normal optic disc should have a cup of about 0.3 or 30% of the diameter of the disc. No spontaneous venous pulsation. No effacement of blood vessels on the disc. So this would be, as we'll find out, kind of a low-grade Frisén scale papilledema. Confidential visual fields are unremarkable, except that the blind spots were greatly enlarged compared to the examiners. Hearing was intact. Everything else was pretty much normal. Now, at this point, I'd like to call Dr. Romo to come up, and we will demonstrate to you how to test for enlarged blind spots. So I'm the patient, and you want to test my blind spots.
Okay. So can you cover your right eye, please?
Okay. Let's do the other one so they can see it.
Okay. So please tell me when you stop seeing my thumb.
Now notice he's going to extend his arm so that he's at 2 arm lengths from me, so that his thumb will be equidistant from our 2 eyes. Okay, now, so I'm looking in your eye, yes.
And tell me when you stop seeing the thumb.
It went away. It's back. It's back. It's there. You need to get it in the blind spot. There you go. You're in the blind spot now. Okay, I can't see it at all.
I can see it.
Okay, I see it.
Okay.
Bring it back in the blind spot. Okay. I see it. It's gone. Oh, let's come back a little bit. I can see it very well there. Go up a little bit. Yeah, you're getting in the blind spot. So basically, you match your blind spot against the patient's blind spot. And when your thumb is in the blind spot, the patient won't be able to see it. As soon as you move it out, they see it. So you can actually, like when I did this with her blind spot was about 4 times as big as mine. Thank you. A little something that you can put into your armamentarium of testing. It's a lot cheaper than getting an MRI. It's cheaper than getting fundus photos. Anyway. So I diagnosed her with migraine without aura, medication-abused headache, and recurrence of IAH after cessation of esomalt therapy. And she was kind of crying in pain. And in order to expedite things, I ended up admitting her, and actually Dr. Worm, I think, was taking care of her in the ward. When she went back to the eye clinic, and I'll show you her fundus photo, she was confirmed as having a recurrence of papilledema. 2 lumbar punctures were performed. Actually 3. One was attempted by neurology, which is crazy. Do not attempt a spinal tap on a 400-pound patient. We don't have the needles long enough to do the job. Okay? IR got in, but they couldn't measure the pressure. Neurosurgery got in, but they measured the pressure with the patient sitting up, which is ridiculous because it doesn't mean anything. But interestingly, neither of these relieved her headache. That's another point. This kind of disjointing of the headache from the actual internal pressure. It's something that happens all the time. It's very frustrating, but you have to learn to deal with it. So I finally took neurosurgery to do some internal Icp monitoring, and she agreed to it. But then she went down to the ASIC, and they told her that she would have to stay in the SICU for a week or 2, so she refused. So unfortunately, there is no bariatric surgery being performed at UAMS these days, but actually I'm pursuing an outside bariatric surgery for her. And she's on Diamox and fentanyl patch. So that's her. The disc photos are very poor quality, and one of them was unsuccessful. But just one of the residents yelled out, "Which eye is this?" Left. Very good. And you can see that the disc margins are very much blurred. There is a halo effect. The blood vessels are fairly well seen, but the cup is pretty much filled in. It's very hard to look at a 2-dimensional fundus photo and determine how big the cup is. And really, the ophthalmologists have ways of actually seeing the optic disc in 3 dimensions. And sometimes they can take stereo pictures that you can play on a ViewMaster machine. How many people know what a ViewMaster is? Very good. look it up on the internet. Anyway, so she has some papilledema, and these are her Humphrey 3-2 visual fields. Basically, nothing there. So let's talk a little bit about papilledema and idiopathic internal hypertension. This condition was first named Pseudotumor Cerebri by Max Nonne, who was a German neurologist. In 1955, it was changed to benign internal hypertension, but then people kind of scratched their heads and said there's really nothing terribly benign about a disease which can cause irreversible visual loss in 25 to 31%, depending on which series you want to believe of the patients. Actually, Quincke was the first one to report on this condition. He's also the first person to stuck a needle in someone's back and measured the pressure. Walter Dandy, a neurosurgeon, I guess at Hopkins, first published diagnostic criteria for this condition in 1937. And in fact, he came up with the first surgery, which was a subtemporal decompression. So the original Dandy criteria were you have to have signs and symptoms of increasing current pressure and opening pressure of greater than 25 centimeters of water. No localizing signs with the exception of abducens nerve palsy. And as you know, 6 nerve palsies are really a non-specific finding due to increase in current pressure or decrease in current pressure. Both conditions can. And it's basically due to the fact that the 6 nerves are tethered at the Dorilus canal, and as the brain moves up and down with varying pressures of the spinal fluid, it will pull on the 6th nerve and kind of make it angry so it doesn't want to work anymore. It's not a meningitis, so the CSF composition has to be completely normal. If you have cells in there, it's not idiopathic internal hypertension. And the split ventricles and imaging with no intracranial events. Unlike normal pressure hydrocephalus, where you have huge ventricles, in this condition, the ventricles are tiny, which, as I'm going to talk later, becomes a problem when the surgeons want to do a ventricular peritoneal shunt, for example, because there's very little ventricle to get to. So J. Lawton Smith, who is a giant in the field of neuroophthalmology, passed away a couple of years earlier, published the modified Dandy criteria in JCNO in 1985. And he, obviously when Dandy was around, they didn't have MRIs, let alone CAT scans. So Lawton Smith came up, put in the CT scanning as part of the diagnostic tool. And Kathleen DeGray at Utah and Jim Corbett in Mississippi then further refined the criteria in a review in the neurologist. That's misspelled, by the way. I didn't accept my last version. It's C-O-R-B-E-T-T, not Corbett. So DeGray and Corbett basically said that they want to exclude this condition when it was due to cerebral sinus thrombosis. And that kind of makes sense, because there you have a very clear-cut etiology, and it's nothing idiopathic about it. Then Deb Friedman and David Jacobson published the most recent modifications of Dandy's criteria the next year in neurology. They're kind of liberalized things. They said you don't really have to have any of these symptoms. You just have to have enough information that you glean from it that they have increased pressure. And they said, no more sitting the patient up and measuring the opening pressure. They have to be in the lateral decubitus position. And also they tried to address the controversy about getting MRV. That's MR venograms. Obviously, you want to rule out it's cerebral sinus thrombosis, but then there's a cerebral sinus stenosis, which is much more of a controversial topic, which we'll address in a little bit. So here are DeGray and Corbett's criteria. I'm not going to bore you with all the details, but it's not that much difference. They do require that the patient be awake and alert. You cannot diagnose this condition in a comatose patient. Incidence is about 1 in 100,000 in the USA. If you look at studies that have been done, it's a little lower in Iowa and a little bit higher in Louisiana. So 0.9 in Iowa and 1.1% in Louisiana. And probably because there's obesity is not uniformly distributed in this country. Tends to follow a north-south gradient. 90% of patients with IAH are women, and the highest risk group are women who are obese. More than, again, I'm sorry, for some reason when it didn't capture my last version of this. So it's an older version. The highest at-risk group are women between 20 and 44 who are at least 15% above their ideal body weight. And they have a risk of 19 per 100,000, so almost 20 times as high as the overall risk. That doesn't mean that older people, people who are skinny, and even kids cannot get this condition. Of interest that when adolescent children get IAH, they usually are similar to their older counterparts. So they tend to be obese and they tend to be women. Whereas if you look at prepubescent children, they divided equally among the sexes and they don't necessarily have to be obese. So there's something a little different.
Sark, what happened to menstrual irregularity?
There have been studies that show that there's a relationship with polycystic ovary disease and.
Well, the old criteria was women obese with menstrual irregularity.
That's not part of the definition anymore, but certainly there's data that show that they're not uncommon because there's obviously a lot of hormonal influences. For example, progesterone causes increased heart pressure. So. Well, acetazolamide or Diamox is a heterocyclic sulfonamide which was designed specifically when sulfonamide was found to have a weak carbonic anhydrase inhibitor. Now, when they synthesized acetazolamide, they made some changes to the sulfa moiety of sulfanilamide. So one thing to keep in mind that even though acetazolamide is a sulfa derivative, you don't necessarily have to have cross reactivity in terms of allergic reactions. So it's always, if you see allergic to sulfa, don't back off immediately. You proceed with caution, but you can proceed nevertheless. Because if you just give up, you're really depriving the patient of potentially sight-saving treatment. Now, there are some individual case reports that actually put bolts in people and put them on acetazolamide and tried to determine what dose you have to get up to where you can actually start lowering the intracranial pressure. And it's about 4 grams per day, which is a huge dose. You start people at 2 kilograms twice a day, which is pitiful, laughable. But people feel so bad when they're on Diamox because they're in a chronic metabolic acidosis. So they feel tired, they feel weak. Plus, there's an increased incidence of, for example, kidney stones. There is some potential for transaminase elevations. The other thing is they get paresthesias, oral and acral paresthesias. They get metallic taste in their mouths. And so when you drink something, a fizzy drink like a Coke or something, or the Dr. P, it'll taste horrible. And actually, that's my, there's not a lot of data, but my personal hypothesis about Diamox and its substitute effect on people with IH is that I think studies show that the average American gets about 20% of their caloric intake by soft drinks, carbonated beverages. And if you take a medicine that makes the Coke taste horrible, well, it's kind of like being on antabuse. You're going to stop drinking Coke. And so and I'll show you some data actually from the Nordic trial, where the people in the we'll get to that one, but the people on the Diamox arm lost a lot more weight than the people on the placebo arm. So the question is then, is Diamox actually lowering the intracranial pressure by some kind of a mechanism, by inhibiting the production of CSF, or is it actually making people lose weight? And so if patients with IH lose about 5 to 10% of their body weight, they usually get better. So it's just a matter of getting them there. This is all out of whack here. Excuse me for a second. Oh well. I guess when I was trying to save this, it totally screwed me out. I guess I'll have to. Well, we can take a break, and I can try to load this is a very early version that for some reason was not replaced by my current version. If you just take a little break and let me see if I can load that one up.
Do you have a review or?
That's in my computer downstairs in my office. So, let's take a short break. Excuse me. I apologize for this.
Chair of basic science.
When we get through,
So where we need to put the phone number? Yeah. Probably but then if anybody wants
we can pass these around. Are there enough of these to go around?
there's 10, I don't know how many you want.
Well, I don't know how many people are well, there's so
This is well, like for those who don't have a cell phone, some people can go restaurant.
Well, I think I tried my $15 Walmart phone. I was the last cameraman. She had a smartphone. Well, I really need $100. So surgeons impact residents. Well, David, well, we can usual sign sometimes we use this okay, so, sorry, just because we're trying this new sign-in. So, it may not have been entirely clear from what was going on, but faculty need CMA credit for this. What you need to do is write your cell phone down here so that when you text the number, when you dial in and tell them what event you're at, they know that it's you. Otherwise, if they don't have your cell phone, they have no idea who it is that just registered. So we're going to circulate this among faculty so we have your cell phones, and that makes it easy. Residents, you don't need CME credit, but you do need to sign in to show that you're here. And with that, we can use our usual clipboard. We'll just put a Grand Rounds thing for the date and just sign in the usual lecture attendance. So
Are you going to keep that? I'll have to.
And so I'm going to circulate this among faculty, but the only people who need to sign on to this are faculty. Okay. And we've got some other ways to sign in. And again, this is just for CME credit purposes. It's not for anything else. So I'll start this around.
Well, I have one, I just don't use it, so one thing to use it, I don't want to get it on work. I already know my stuff. Is it a smartphone? It's just, but it's regular, and mine will do it. Here's a new word. You know, I've just got a cheat, and I only use it when I travel.
Okay, but then you can call. See, like this, I have the app. But yeah, you
One other quick announcement
I'll have to go find out
for faculty and I guess any residents, faculty and nurses and any residents who are really interested. We're having our clinic retreat tomorrow. It's going to be over at the Bessie Glass conference room, 10th floor of the Cancer Center. And the idea behind this is, and this is faculty who have any practice at our neurology clinic in this building. So full-time VA, you guys don't need to come unless you're really interested in this. But I can't imagine that you want to spend your salary money doing this if you don't practice here. And residents, if you have some strong input, some ideas about how to improve that experience, particularly during your clinics, you're welcome to come if you've got time to come. But it is far from required. It's, this is just if you're very interested in coming. But I do want as many faculty as possible to come because this is really our chance to redesign how the clinic works. There is a big push from the administration to fix neurology clinic. And we can't fix it unless we get input into what needs to be fixed and how to do it.
So what are the, go ahead. So what are the symptoms? Well, headache obviously tends to be global. as opposed to a lateralized headache like migraine. And it's there can be pounding, so don't get freaked out by that. Visual disturbances, visual loss, blurring of vision, the transient visual obscuration that we talked about. Diplopia, again, a sixth nerve involvement is extremely common. And photopsias, which are sort of sparklers or bizarre. Those we tend to associate more with retinal disorders, but they can be seen not that commonly. Photophobia is a big one. Tinnitus. There's a lot of theories as to what the tinnitus is due to. I've never tried this, but some papers they suggest that if you kind of put pressure on the jugular vein, the tinnitus goes away. So it might be some kind of venous turbulence. Not clear to me exactly what's going on. Neck pain, shoulder pain, or even auricular pain down the arm is very, very common. And nausea with a MS is very common also. And there's a whole host of medications that are associated with the development of syndrome. So you need to get a fairly good medication history. As Dr. Lucy pointed out, the endocrine system is very, very closely related to pressure issues. Generally speaking, steroids can be used acutely to lower the pressure. But unfortunately, when you withdraw them, then you get kind of a rebound hypertension type of thing. Again, progesterone, danazol, tamoxifen, human growth hormone, and anabolic steroids. For those of you who want to bulk up, you might have to put up with some headaches. And antibiotics, tetracycline and its derivatives, naldixic acid, nitrofurantoin, which are of historical interest. Anybody here use any one of those antibiotics recently? Probably not. Indocin and I think rofecoxib is one that was pulled from the market, right? So we don't need to worry about that. And the vitamin A compounds, retinol, the various retinoids. So if you are, for example, if you're stuck in the North Pole and the only thing available is polar bears, don't eat their livers because they're loaded with vitamin A, and you get a terrific headache, and you won't be able to see very well. Lithium and cimetidine. So here's Dr. Friesen's original, the photos from his original paper, but it's a way of grading the papilledema, and it's very useful for publications and stuff. I find that it's kind of confusing. So what I'm going to do here is I'm going to show you a video. I shouldn't say video. A generation too late for being very successful at this technology stuff. This is actually Kathleen Digray and Jim Corbett who came up with this, and it's I couldn't do any better, so I'm just copying them. It's not plagiarism because I'm giving them credit. So this is Friesen scale, grade 0 papilledema. You always, the nasal half of the disc is always going to look fleshier than the temporal half. Because remember, the temporal half is getting the papillomacular bundle. So it's a fairly limited area of the retina. It's a tiny portion of the retina, even though all the important work is being done there. And all the other fibers have to come around the papillomacular bundle and enter the disc in this section here. So that's always more fibers nasally. But you should have a nice cup, like I said, a 0.3 cup. And when you go to grade 1, now there is very much enhancement of that slight asymmetry. And there's a C-shaped swelling So again, the macular bundle is spared, but everything else is kind of elevated. However, you can still see that the temporal margin is very clear, and the cup is still there, and the blood vessels look very good. When you get to stage 2, now you have elevation of the temporal side of of the temporal side of the disc in addition to this peeping up on the nasal. However, well, this is not quite true. I mean, you shouldn't have any vessel obscuration, so this is probably a grade 3. Anyways, I love them anyways. Now, with the grade 3, the whole thing is swollen. You're getting the halo effect all around, and you're actually starting to see the blood vessels getting obscured. Right? And the reason they're getting obscured is because the nerve fiber layer is swollen, and when it gets swollen, it's no longer transparent, it's translucent, so you can't see the details underneath it. Grade 4, hardly see the vessels, everything, you get this big halo, you can kind of see that the swelling now is reaching out here, and that's why you have this enlarged blind spot, because as you get more and more papilledema, the swelling is involving the adjacent retina to the optic disc, and as such, remember the retina is arranged so that the light has to go through all the layers of the retina before it gets to the photoreceptors. So if you have a swollen edematous retina, well, it's going to not allow the light to get to those chemoreceptors, photoreceptors. And this is kind of called champagne cork papilledema, where everything is just one big swollen, pussy mess. They also have very good examples of these things, like patent lines and retinal choroidal folds and stuff. Let me show you. Here are hemorrhages. A lot of times they're kind of flame-shaped or nerve fiber layer hemorrhages. Anytime you look at a disc and you see a hemorrhage around it, folks, it's not normal, it's abnormal. Okay? And here this is a subretinal hemorrhage here that's layering. As you can see, there's a air or vitreous blood interface there. You have all kinds of hemorrhages. Here are Peyton's lines. They're concentric rings where the swelling in the retina is kind of pushing the retina apart, so it causes those wrinkles. And choroidal folds, actually that's the choroid, not the retina, which is being kind of crumpled by the fact that this is coming up and displacing it. You can even have partial macular scars. I've never seen it, but obviously they have. And then when you're done with it, here is what you're trying to avoid, because now the disc is atrophic at this point, right? But unlike primary atrophy, where the disc looks like an aspirin tablet is chalky white, when you have secondary atrophy, which means that it's atrophy as a result of long-standing papilledema, you'll get gliosis on the surface of the disc, so it looks kind of hairy, is a term that's used in the neurology literature. There's all this gliosis on top of the disc. And you have the high water mark, see? That's where all the retinal swelling was, and it's gone away. Which it brings a very interesting point that once a patient reaches this stage, they can develop incredibly high pressures, and the disc isn't going to swell anymore because it's gone. Right? There's nothing to swell anymore. Enough axons have died that you're no longer able to produce that. And here's why. Now, this is something that you would see theoretically in a patient who's had a optic nerve sheath fenestration. Now, the fenestration, we're going to talk a little bit more about it later, but you can go in there and actually put a slit, or sometimes they take a little window out of the optic nerve. So now this fluid is spilling out into the orbit, and the pressure goes down. However, what the long-term benefit of this supposedly is when the the area that you put the slit in, the sheath actually scars up and becomes adherent to the optic nerve. And now the pressure can no longer be transmitted to the optic disc itself. And that's why, for example, in this case, you have florid papilledema on this side, but nothing's happening here, because you have somehow taken the ability of the internal pressure to get to the optic disc level. All right, well, that's good. Hope you enjoyed that. I'm sorry we did. Now let's see if we can get back here. All right. Enable editing, right? Now some unknowns. I'm not going to call on anybody, but any of if the students feel confident, or any student want to comment on what this looks like? How about residents now?
Very proliferative.
So is this papilledema or not? This papilledema. What grade? This is champagne pore papilledema, right? This is for Zen grade 5. How about this one? Actually, it's not atrophic, but what's this thing? What's all this edema here all about? Well, it's not edema because it's not on the disc, right? This is the disc, and you got all this white stuff, fluffy stuff. Anybody know what that is? It's off the disc. It's not bruised. Now, these are myelinated nerve fibers. You see them occasionally. When I see them, I always try to get as many residents in the room as I can to show them. But theoretically, when you have, every axon has to be myelinated, right? These are kind of visual information. But you can't myelinate axons when they're on the retina, because they'll block the light from going in. So the myelination only occurs when the axons make that 90-degree turn and head down into the optic nerve. But in some cases, they get myelinated, the myelination, the oligos go crazy, and they myelinate where they shouldn't. And this is what happens. Now, this patient is going to have an enlarged blind spot. How about this one? Look at this juicy baby up here. Come on, one of the residents has to give me this one. Somebody in the back shouted it just a minute ago, for God's sakes. I think it was Dr. Bianchi, right? I can hear. Optic nerve drusen, very good. Drusen are, this is a collection of proteinaceous material. All right. How about this? Is that a swollen disc?
Yeah.
Yes.
So grade 2.
I'm sorry?
Grade 2 papilledema.
Well, it's hard to tell the grade here because it's not acute. Remember we talked about the kind of fuzzy appearance? This is a disc that has been swollen for a long time and is heading towards the graveyard. Basically, this is chronic papilledema. You can see that it's kind of starting to get kind of slowly going towards pallor. That's an interesting one. There's definitely swelling in this disc, but where is the swelling? This is the disc, right? And where is the swelling? Up here, right? So the top half of the disc is swollen. The bottom half of the disc is normal. So it's a different process. This actually, in ischemic optic neuropathy, the nerve has infarcted. And this patient is coming with acute vision loss because they just had a stroke. Right? I feel this isn't just because it's so neat. Anybody have any idea what's going on here? Yes, well, it's yes and no. People call these shunt vessels, but they're not. They're actually venous bypass vessels. If you have a central retinal vein occlusion, or if you have a optic nerve sheath meningioma, something that is occluding the central retinal vein and not allowing the blood to drain out of the eye that way, then there's a choroidal venous system which drains the eye too. But the two systems don't really talk to each other. The only place where they come into close contact is at the optic disc. So these are venous bypass vessels that drain the retinal venous blood into the choroidal circulation, and thus they can get out. Okay, this is papilledema, right? See the blood? Not normal disc. So what grade are we going to call? Are we losing vessels here crossing the disc? Yes. Is there a little cup here? Yes, you can still see the little cup. So is this a grade 2 or 3? 3, very good. Visual field, I'm sorry, I'm kind of running late. I'll try to go fast. So enlarged blind spot is very, very common. Then you get these arcuate defects, and we'll talk quite a bit more about arcuate visual field defects in our neuro-ophthalmology talks, but essentially they start the blind spot and then move to the nasal retina, and they're due to a process that's affecting the optic disc always. And eventually you get into severe visual field constriction, which our patients have. Okay, how about the MRI findings? Here is a saddle that a certain member of a Middle Eastern empire used to sit in, right? So what is it? What is it called? Pseudotumor, very good. So that's empty. Basically, the pressure is kind of mashing the pituitary to a pancake which lies at the bottom of the... Now, the other thing that you'll see is, if you draw the little line here, you see that the cerebellar tonsils are actually protruding a little bit into the canal. But this is not Arnold-Chiari malformation. I had a whole session about it at the Nanos meeting a couple of years ago. This is just the brain kind of settling down. Because if you have an Arnold-Chiari, you're going to have deformation of the tonsils. They'll be peg-shaped. These are nice and round and juicy. How about the orbit? Now, there are several findings here. One is you can see all this abundant spinal fluid in the optic nerve sheath surrounding the optic nerve. You can see that there's flattening of the back of the eye where the optic nerve is connecting. You can't see, but it will contrast enhance. It isn't something funky going on there. And actually, Brodsky and Bafiatis, who were at UAMS at the time they wrote this paper in '98, I think, looked at things and kind of tried to come up with, there were 20 patients and 20 controls. And they found that this scleral flattening is the most sensitive sign. Although the most specific sign, although not terribly sensitive, was the prelaminar enhancement of the optic nerve. So another thing also is when you do a fluorescent angiogram, the optic disc will shine very early. Whereas if you have a drusen, the drusen will shine later on, at the end of the study. Tortuous optic nerve sheath distension. So these are all good things that you can. So we'll talk a little bit about nicotinamide. We talked about the doses. We'll talk about side effects. So let's move on. People use diuretics. You have to be careful because if you the combination of Damax and diuretics can cause hypokalemia, which is not always a good thing. There are many papers that show if the patient can lose 5-10% of the body weight, the pressure comes down. Serial lumbar puncture is, you saw what happened to this lady, right? I mean, she actually developed an aseptic meningitis with multiple needles being stuck. And again, because these spinal taps are difficult to do because of the patient's size, you're much more likely to do repeated sticks and introduce bacteria in there. Bariatric surgery, no data, but certainly makes sense. How about the transverse venous sinus stenosis? Now we know that if they have if the sinus thrombosis, then it's a big emergency. But how about the stenosis? Well, we think now that the stenosis is actually due to the pressure kind of compressing the sinuses. But still, that's a problem because you're having trouble draining the fluid out.